Thank you. Hello and welcome to our August 2020 LabCorp session, which we host monthly to share our best practices that will improve our lab systems and cascade of testing in general. Today, we will be focusing on EQA, proficiency testing, the coverage, results, and sustainability, as well as the perspectives of service providers. As we know, EQA is something that is so important that at times is not given its due importance that it requires. To do this, we have key experts that we have in the industry, in the name Sean Nguyen, who is a biologist in the viral load and EID team at the International Laboratory Branch Division of HIV/AIDS at the Center of Disease Control and Prevention, US CDC, as well as Daniel Taylor, who is the co-founder of One World Accuracy. Before we start, just a few notes on the logistics. This will be a 1-hour session as usual. We shall start with 2 presentations, after which we will then have a question and answer. Remember, kindly put your questions and comments in the chat box as the session goes, and we shall attend to this immediately after the presentations have done. We shall start with the presentation from Sean Nguyen, who has been serving the PT program as a coordinator for the viral load and EID proficiency testing program since 2010. These 2 proficiency testing programs support over 300 labs in over 50 countries, and she manages all activities from planning, panel production, as well as to results database management. For program sustainability, her team has been providing training for PT technology transfer to countries in order to establish their own PT programs. She works closely with country PT program managers for continuous monitoring of in-country PT programs, as well as providing ongoing technical assistance, as well as sources of the viruses, as well as other materials for panel production. Colleagues, let me welcome Sean to take us through the first presentation. Over to you, Sean.
Thank you, Anafi, for that introduction. Thank you, everyone, for joining in. Good morning from Atlanta, Georgia, and good afternoon, good evening for all of you from everywhere. Thank you for taking your time to join in. My name is Sean Nguyen. I'm a biologist and from for Viral and Early Infant Diagnostic Team in the National Laboratory, ILB, and Divisions of Global HIV and TB from US CDC, Central for Disease Control and Prevention. The title of my talk today is going to be the establishment of HIV viral PT providers. Here's the presentation, my outline of my presentation. I will start with the quality of Sean, and then CDC HIV-1 viral proficiency testing program, and the country with the viral PT program to our technology transfer, and then CDC viral PT program production using the alternative virus source, which is the live flight virus, and then the accomplishment and next step. As we all know that many countries are scaling up viral load to meet their UNA's target for 90 by 2020, which is this year. And then many countries are now moving on to 95 to meet their target by 2030. For the first 95, just a reminder which is the 95% of those people who are HIV positive to be diagnosed. And then for the second 95, those 95% of those people who are diagnosed to be on treatment. And then for the third 95, for 95% of those people on treatment to have a virus suppression. And here we come in for the third 95 for 95% viral suppression rate. WHO recommended viral monitoring of treatment efficacy at 6 months and 12 months after initiations of ART, and then annually thereafter for people with suppressed viral. And here suppressed viral is defined as less than 1,000 copy per mil. And the plasma viral is still the gold standard for viral monitoring, but many countries do not have the plasma viral for limited cold chains or lack of cold chains. So they are using the DBS as a as an alternative for plasma viral monitoring. And I'm going to go over to the quality assurance activity. So for this is going to be focused mostly on the laboratory, begin with the safety, quality control, and external quality assessment, and then record keeping or document control, and then others. For the external quality assessment, it's involved 3 activities. It's for site visit, retesting, and proficiency testing. For site visit, a team of supervisors assess the site and provide feedback report to the for improvement to the laboratory. For retesting, random selections of clinical sample collected by a testing site and then send it to the National Reference Laboratory for verification. So this usually done all positive sample and 10% of the negative sample. And then for proficiency testing, that's where we are going to be focusing on today, testing the blinded sample at regular interval for all participants. So usually send out, for our part, we send out 5 samples. In the past was 3 times a year, and now it's only 2 times a year due to the number of participants been increasing so many. And then here we have the proficiency testing benefit. There are so many benefits here, just a few that I have listed. So it provides the early warning of systematic problem, and then increase confidence in the quality of laboratory performance, and then also as a quality indicator for stakeholder at various level, and then quality evaluation and improvement for the testing process, and then is demonstrate the employee competency, and to monitor the trend of result in quality. This is usually done over time. And here is the proficiency testing process. It's involved 2 parties, which is the provider, PT provider, and then the participant, which in this case can be laboratory. And PT provider would prepare the sample and then send that sample to the participant, and the participant then examine the sample as they would normally do with the patient sample, and they test those samples and then reported the result back to the provider. And the provider would then analyze the result and then generate the report and then send it back to the participant. And the participant then evaluate their result by comparing their result with the peer result or the reference result. And if anything underperforming, then perform the corrective action as needed. And then the provider can also provide guidance on how to improve their performance as well. And proficiency testing sample, as you see, the process begin with the sample preparation. So we're going to talk about the sample type. At the sample type, as of now, we have the liquid. The liquid sample involve using the serum and plasma from the clinical sample. This require cold chain transportation. It could also increase the risk of spill. And it's expensive to maintain the cold chain transport, and then biohazard, biosafety issue could occur. And dry blood spot or DBS can be transported at room temperature, and it's inexpensive, can be used for HIV-1 viral or early infant diagnostic testing. And then and the next one we use is the dry tube specimen or DTS. This can be transported at room temperature, it's inexpensive. This can be used for all HIV-1 viral based on PCR. And then these are the existing viral tests that in the market. And this our viral PT program is work on all existing HIV viral tests that based on the nucleic acid amplification test. And here's the CDC Viral PT program. And CDC Viral PT program supported, as Anafi mentioned earlier, we provided more than 300 laboratories, to be exact, 388 laboratories in 56 countries as of in 2019. And then our feedback survey indicated PT have a huge impact on the laboratory performance. 94.8% of those enrolled laboratory reported improved performance over time. And our proficiency testing process, so we will focus on the laboratory activity in the sample preparation. And CDC uses the dry tube specimen. The dry tube specimen will prepare for dilution of cell culture supernatant that have high viral concentration. In this case, we're talking about 10 million copy or more to cover the wide range of HIV-1 viral test that is in the market. And the HIV-1 infected cell culture supernatant is the only virus source that available for ILB. And many countries are having challenge to get the high titer viral from the clinical sample due to the implemented pre-screening test. Viral PT program extension. So the use of this frozen live virus stock for DTS preparation is the major limitation to establish the in-country viral PT program. Many countries do not have cell culture capacity. Shipment containing virus, live virus are expensive and could also be hazardous. So that's why we explore the need to find the alternative source of virus for the sample preparation. So this virus source have to have a high viral concentration. So this is needed to transfer the DTS technology to the field to expand the program for building in-country capacity, sustainability, to continuous monitoring of laboratory performance to help to ensure high quality result. And live virus have been identified as our alternative source of virus. It's a that is used for the DTS viral PT panel production. It had facilitated DTS viral PT technology from ILB to the field. The benefit of in-country PT program establishment include building in-country capacity, ownership for program sustainability, reduced result turnaround time, as well as the reduced program logistic costs. In this case, would be the shipping within the country instead of the international shipment that require custom clearance and approval. And here is the list of countries that would establish viral PT program to our technology transfer provided by ILB. The first country we transferred to was in Senegal, Kadu, in 2015. And the next one was Kenya in NHIL in 2017. And then followed by India, NARI in 2018. And South Africa in 2000. And South Africa and HL in 2018 as well, and then to Ethiopia, EPHI in 2019. And ILB provided live virus to all sites except India. India had the cell culture capacity, so they generate their own cell culture supernatant. And countries that have requested the need to establish viral PT program to our technology transfer process include Burma, Cameroon, Kazakhstan, Nigeria, and Papua New Guinea. And then this is the graph showing the CDC viral PT program. And we began providing the viral PT programs in 2010. And we transferred the technology to Kadu in 2015 and followed by NHLS in 2019. So as shown in here. And here the country and the participants. So the number of participants has been increasing since the initiation. So from 32 participants in 16 countries in 2010 to 388 laboratories from 56 countries by 2019. And here's the result from the in-country viral PT program. So the first one we transferred to the earliest transfer was to Senegal, Kadu. And the number of lab and pass score of the trend in this graph showing. As shown here, the majority of participating laboratory receive pass score at each PT round. It's the accomplishment and the next step. For accomplishment, our team also work closely with WHO for the WHO PQ for the monitoring of the HIV molecular testing. This provides a framework for the sustainability of the molecular testing in the field. And then the boxes highlighted in blue, the one that had been completed the WHO PQ. And all this WHO PQ was done in collaboration with the NHLS in South Africa, except one that was done with the, Cote d'Ivoire in Retro C. And for our future plan, include the last productions of the QPC panel or in a kit format to support the Center for Excellency in South Africa, Senegal, Nigeria, Uganda, Kenya, and Cote d'Ivoire. Before 2008, just to mention that NHLS was the only ISO accredited lab. And then after 2008, well, now we have so many lab that is accredited WHO PQ assessment completed to serve as the new technology evaluation. And then to this last still production, we're going to be used for the PQ evaluation and evaluation and validation of the new technology and the instrument. And then we can also use that to support the verifications of the instrument and assay, and then for lot-to-lot verification at the national and local level, as well as as presented here for the proficiency testing program to establish the proficiency testing program for in-country. And then also can be used for training and competency. So our team will provide the technical support, SOP tool, as well as data analysis support, online data tool for the quality management system. I have received many support from for this program, for this project from CDC ILB, as well as from different branches here at CDC Atlanta. From the Division of Science Research, they provided the lyophilized virus service, and for DHAB, Division of HIV and AIDS program, provided our cell culture supernatant needed for this program. Thank you for your attention.
Thank you very much, Sean, for the wonderful presentation. And I'll ask you colleagues to hold on to the questions, and we will take them at the end of the second presentation, which will be provided to us by Daniel Taylor. Daniel is the co-founder of One World Accuracy, a Vancouver, Canada-based accredited EQA provider. He operates with a social enterprise commitment to make EQA globally sustainable. That commitment, he says, is expressed in the EQA Africa, an initiative which was started in 2010 to create a network of collaborative EQA in every African country, where to date they have about 30 current and aspiring national EQA providers in the continent. So Daniel today shares his insights on how applying basic economic principles can improve EQA sustainability in Africa and beyond. Over to you, Daniel.
Thank you very much. There. Thank you. Thank you for organizing this. Thank you, Sean, for an excellent presentation, which literally lays the groundwork for external quality assessment and EQA. And this is this presentation is a companion piece to a paper that was submitted to Lab Culture, and it's hopefully soon to be published. And essentially, it takes a set of what we think are quite straightforward economic principles and applies them to the proposition of improving EQA sustainability in Africa and globally. So what I'm going to cover is our group, what we call collaborative EQA. And then I want to outline 5 practical suggestions that we feel can improve EQA sustainability everywhere. And then I want to conclude with a way forward that might actually make some of these suggestions easily accessible and applied. As mentioned, we're based in Vancouver, and we've been around since 2000. Our head office is in Vancouver. We have a satellite office in Italy. This is Messina's in Sicily. And as mentioned, we operate with a social enterprise commitment to make EQA globally sustainable. And what that means is everything we do is oriented to provide the highest level of clinical relevance for EQA at the lowest possible cost. So the idea is not to cut any corners, but to maintain standards and try to make those standards as accessible as possible. So our commitment is informed by the fact that we manage comprehensive accredited EQA programs in Canada, the United States, and Europe. In the United States, the programs are provided through a Centers of Medicare and Medicaid supported credentialed EQA provider. We have a comprehensive set of programs that span all clinical disciplines. And in ISO speak, we measure about 2,400 measurands or analytes. And my discussion today is really in our capacity as coordinator of what we call collaborative EQA. So collaborative EQA starts with the goal that, and with the political realization that EQA ought to be organized in country by the appropriate public health stakeholder with a public health goal, not a commercial goal. And typically, the groups that are involved are national reference laboratories, institutes of public health, or some other part of the Ministry of Health that has responsibility or oversight of laboratory infrastructure. What we try to do is provide a turnkey set of services so that when the appropriate stakeholder says, we want to take advantage of the Access Collaborative EQA, that we can then have them up and running within weeks. And in essence, this turnkey strategy means providing an informatics system they can use to run all of their EQA programs, all of the training, and more business development advice to enable groups to start their programs and keep them going. And a key part of this is the sample strategy, which we can summarize as essentially every country ought to make or procure wherever possible or feasible with training from us or groups like Sean's to make their own EQA samples. We started training countries to make bacteriology samples that would cover the glass pathogens. And these are simulated clinically relevant samples, but the advantage is that they're not held up at customs, they're not lyophilized, and they're then used within country at a fraction of the cost and complexity of importing from international sources. Early infant diagnosis and viral load samples are also part of that same set of samples that should be made in country. Now, many programs, in-country production is not either feasible immediately or even feasible or desirable ultimately. And many chemistry programs which have a peer group based assessment criteria and which have a lot of technology needed to develop them. For example, hematology, 3- and 5-part differential in many chemistry programs. There, what we do is we provide access to all samples that are within the scope of our accreditation, and we make those sample sets available with informatics at cost. So as I mentioned, these programs ought to be developed, they're already at 17043 and they already meet CMS requirements. So when a country can adopt a program, they know that they are providing a program which meets those accreditation standards. So collaborative EQA really started with the WHO manual, and we've trained more than 30 African public health stakeholders. And the sad thing is that it seems to be easy to start a program, but it's much more complex to keep it going. So here are some practical suggestions that are gleaned from our 20 years of experience. So the first is create a business plan. Now, you have to plan. If you're an EQA provider, you need to plan for long-term sustainability. And so increasingly, when we start with a group, we start with the legal framework for EQA in their country. What are the drivers for EQA? Is EQA mandated or is EQA voluntary? Does EQA cover public laboratories, private laboratories? What is the framework by which EQA can extend to cover the laboratory testing in a country? Now, if you're working with a government group, often it's very difficult to get a firm grasp on the cost structure. So generally, does the EQA provider have to pay rent or account for rent? Do they have to account for their staff and their equipment? Or is that included as part of their other activities? So generally speaking, when an EQA provider is starting, they have to understand what costs are fixed and what costs are variable. And one of the key areas that we feel is systematically underestimated is informatics. So most people, when they describe EQA, they seem to think that once you have a panel, that everything else, goes smoothly. I say, listen, when you want to have a race car, the teaching a country to make the gas is just the starting equation. They say, here are the panels. Now just build or create your own informatics system. It's like saying, build your own car. Now, we need to develop explicit revenue models. Who pays for what? So we recently did a best practices EQA benchmarking session with a large EQA provider in Africa. And they had a very complicated situation where they said, well, we get funding from the government to do the public labs. We don't know what to do with the private labs. And international labs, we charge something extra. And we never really know if we've got enough money to make everything work. Well, that's a complicated but not atypical situation. If you want sustainability, you have to be able to account for that complexity and distill that to a price per category of participant. And more importantly, we often get involved when there's international funding for EQA. And then when the international funding ends, the participation ends. Well, you can't have a sustainable EQA program. That signals that it's not important enough to continue. So we're increasingly asking the very indelicate question, what happens when the international funding ends? How are you going to continue these programs? The second is countries. I was asked to join a scientific advisory board, and someone asked a very simple question, which I took a while to think about. They said, well, how do we allocate a limited budget over so many diseases and so many participants? And I thought about that. Well, a country ought to select programs based on the local burden of disease. And this is a screenshot taken from an excellent site developed by the University of Washington Department of Global Health and the Institute of Health Metrics and Evaluation. This is the global disability affected life years. Now, this is just a screenshot, but I really encourage countries when they're doing this, looking at starting or continuing an EQA program, to reference their local burden of disease. So the principle is you should select programs that are corresponding to your local burden of disease. And here's the definitive data set. Now, they've done an amazing job because they've taken very complex concepts and concentrated them into a single metric of disability adjusted life years. So they take every disease entity and they add up the premature deaths and the disabilities. And this, I think, is an excellent place to start with how to select your programs. Now, the second, the third is that you should prioritize participants by test volume. Now, this seems intuitive, but it's not operational. So an EQA subscription has a fixed cost independent of the test volume of the participating laboratory. However, the value of that EQA subscription scales directly with patient volumes. And here's a simple example. Imagine you've got a properly costed $500 viral load program, and you've got to make the economic choice of, do you select laboratory A or do you select laboratory B? Okay, well, I've made this example to show two things. So laboratory B has 12,000 patient results a year. And if you divide the cost of the laboratory of the EQA by each patient test, you can see that the providing EQA to laboratory B is far more economically advantageous. In fact, were you to allocate it to laboratory A, this would be, in economic terms, a misallocation of resources. The problem, of course, is that if you don't know what the patient results are, you can't make this kind of decision. So follow-up, there's great discussion. Because EQA has the word assessment in its name, we're starting to use EQAI, which is external quality assessment and improvement. So this is really, EQA is intended to be a process to identify problems so that you can solve them. So EQA providers should prioritize remedial follow-up based on patient impact. So what we observe in our experience is that without knowing what the patient test volumes are, an EQA provider will typically follow up based on failure rates. And once again, this could lead to a misallocation of resources. So let me come up with an example. So imagine you've got a $2,000 remedial follow-up, which you know works. And that could include sending your expert for a week-long seminar. It could be training, it could be some certification. That's not really the point. If you know that you've got, if you have to spend $2,000 to improve a problem detected from EQA, should you give this remedial follow-up? Should you allocate it to laboratory C or laboratory D? Well, once again, if you were allocating resources based on failure rates without knowing the patient volumes, you would say, I'm going to go to laboratory C. But you would only be improving at best 960 patient results with a cost of $2. Whereas if you were to pick laboratory D, you'd have a much, much better economic outcome. Now, this next one, the other ones I think are relatively simple. This one is considerably more complex. And that is the ability to provide a return on investment for EQA funders. So all of us go to conferences, and everyone on the quality side usually makes a stump speech where EQA is an investment, not a cost. And it's preaching to the choir, and every one of us in the laboratory community nods our heads and gives a hallelujah. But the economists would say, well, if it's an investment, what's the return on investment? And it's very difficult to answer that question. We know generally that it provides some benefits, but the ability to deliver an actual return on investment would facilitate EQA funding. It would facilitate funding in 3 dimensions. First is, if you're asking participants who are laboratories to fund EQA, they should be able to look at improvement that they have within the patient population that they manage. If you're asking government to fund portions of it, they should say, well, listen, we've got 1 million things to fund. What is my return on investment? And of course, intuitively, we know that investing in quality up front can save an enormous amount of downstream cost, which includes reduced retesting, because doctors know that these test results they have confidence in those results, and that avoids the retesting needed to deal with their insecurity about the reliability. Also, when doctors can receive accurate test results, patients receive more, earlier and better treatment, which leads to better healthcare outcomes. If we're able to tie in, here is my baseline performance at EQA, and here is with each test event, and here are the number of patient results out of a total that are now meeting clinical standards, and you can document that from EQA. You can then generate a return on investment which is rooted in the healthcare economic concepts of disability affected life years. And this would then facilitate, in our opinion, significantly the return on investment from all sources of EQA funding. So this is all well and nice, and it's great to have a presentation, and even if there's some great ideas and everybody takes them home and tries to operate on them, but is that really going to have a systemic impact? I think not. So So here's an idea that I offer for this collective to consider. The development of an EQA sustainability dashboard. Maybe it's definitely open source, and it should be available as a resource for EQA providers. And maybe this is somewhere where an organization such as the African Society of Laboratory Medicine could then, channel the resources available to make this a practical online experience. But what might some of the elements look like? Well, first of all, if you're going to make improvements, you have to measure it. And so some of the concepts I've introduced, I think, will play a key role in defining progress. So the first is EQA providers, before they start, and even the current EQA providers, should go back and do a business plan. And there's many different templates. We have started down that process. So essentially, an EQA provider would make a business plan, and out would pop a bunch of questions which would highlight gaps in their process. Biggest one is generally not having a clear enough understanding to price the EQA programs per type of participant, public, private, and international. The second is the data that's available is just absolutely amazing, but we would link this dashboard to local burden of disease. Now, the Institute of Health Metrics and Evaluation provides past, current, and projected burden of disease. In my view, that this is an amazing but underused resource that could be harnessed for sustainability in EQA. Now, not every cause of disability adjusted life years has a lab test behind them. Many of them do, and many of them are very simple. If you've got HIV/AIDS, you'd obviously, to meet the 95, 95, 95, want to have a detection test, both in core lab and in rapid test. You'd want to have viral loads. You'd want to have, for many places, still CD4s. And of course, you'd want early infant diagnosis. And then there could be some associated programs with that, given the opportunistic nature of comorbidity with HIV. Those would be defined. And so therefore, laboratory EQA providers would be able to have the specific tests and the EQA programs associated with them. A key missing piece, which we're adding to what we do, are the menus of the EQA of the participants and their test volumes. And I've mentioned one of the outcomes of the business plan template with this other information is to be able to properly cost EQA programs and to include standard troubleshooting checklists by discipline. So we're actually taking it a bit further, and we're taking some of the best checklists that we found and tried to rework the EQA process. So the end goal is improvement, not just assessment. And this one, I think, requires more brain power because it's very difficult to develop a true cost model. What happens with an inaccurate test result? Well, I know that there are models out there, and there are shortcuts to the models. We need to have an ability, though, to model performance of both meeting clinical standards and not meeting clinical standards, so that those can then generate a credible EQ return on investment for those that are funding this, both government, individual participants and networks of participants, and international aid funders, and arguably the IVD community, who should be engaged in the funding of this as well. Thank you. Those are some of our observations. And if anyone has any comments or questions outside this and would like to have more input into the design of this open source dashboard, feel free to contact us. Thank you very much.
Thank you very much, Daniel, for the wonderful presentation. Very important points indeed. We started with Sean. She gave us a bit of background on the importance of QA in general as we have always talked about, quality assurance is non-negotiable, even in the pandemic, and also testimony to some of the questions that are coming from the chat. And today we have been focusing on external quality assessments and more so also zoning into proficiency testing, which we discussed today. And what is very important to note is most of these in many of our countries are actually being funded by various organizations. And the question that we always ask ourselves is, what is going to happen when that funding goes? And there Daniel comes in with sustainability. How can we make sure that we continue to carry on this good thing moving forward? Since we all agree that quality assurance is non-negotiable. It's time where we take questions from the chat. And if we fail to manage all of them, we will always try to respond to them in writing. So I'll take the first question from the chat. And whilst I'm taking that, just a reminder that we do have language interpretation. So feel free to choose the language of your choice. The first question comes from Eric Opio, who is asking, can someone share a realistic outcome of retesting of the retesting approach where all positive and 10% negative are referred to the national reference labs in their countries? Let me ask Sean to just give an overview of what they have been seeing throughout.
Yeah, thank you for that question. From our end, we don't have any data or realistic data, but if you look at the number of bioload testing have been increasing. Giving an example, you know, if people with just testing 100 sample per day and giving the rate of positive could be 5 to 10%, even you're talking about 95 or 90. So even 5% of those be retested, it'll be a lot. So if you're testing 100 a day, 5 per day, and if you're gonna do it, are you gonna do it every week, every month? So, and then also the sample stability that you have to be considered. So the country, if they are choosing that retesting, they would have to have a strong sample transport system to make sure that they meet the result turnaround time, as well as to be able to control the temperature. Depends on what the sample type they use, but I do not have any example. I'm hoping that some of our participants would have some experience that they can share. Thank you.
Thank you very much, Sean. Whilst you are there, this question came from Dr. Zira. It came by email. And he says he's actually a laboratory scientist preparing DTS for rapid HIV, which you have been supporting quite a lot. And he has quite a couple of questions, which hopefully we can link him to you, such as how do we do the preparation? How long can the virus survive in that dry tube, like HIV dry tube? And then how can we validate the dry tube testing for, now it brings in COVID-19 testing.
Okay, yeah, I have the data to support how long the stability of our DTS. I also have the slide I can share if you allow me to, or should I just respond to him directly?
Yes, you can just give a summary, but it's one important point that we would want to promise our audience, that we should be able to share this as well.
Okay, so do you want me to share now, or just respond to the email, Anafi?
Yes, I think we'll respond to the email. Let's take one more question.
Okay.
In terms of, I think this will be directed to Daniel. This is coming from Wanda May Likano. It also came by email. The main challenge of some of the EQA providing organizers are having organized and having easily manipulated EQA informatics. Is there a possibility to have a common and acceptable EPT system that will be freely customized for different countries in Africa?
Yeah, Wanda Maya, good morning, thank you. So yes, the whole point, and I couldn't really cover this in the presentation. So what are we trying to do? Well, what we're trying to do is develop the technology And this is a multi-tenant technology, so that it means that each EQA provider runs the system as their own system. And then to make it efficient for within each country for a national EQA provider, all programs are then managed on this. So that makes it efficient organizationally for the EQA provider staff and also all the participants. What we're trying to do is to make the system we've developed an open source system freely available for all countries for public health use. And that's our goal. That's been the goal of EQA Africa from the get-go. And we now have a roadmap which would make it a very compelling proposition. And to make this a made in Africa solution, we even have plans to recruit teams of developers within Africa to accelerate what would be a 5-year roadmap with our own resources into, like, say, a 2-year roadmap. And this would then provide the system which would be available for every group to run their programs. But more importantly, if you're sharing an informatics system, not only do you get to share you get to share your experiences. So this could be an opportunity for EQA providers to network and communicate best practices as they go.
Anafi, can I add one comment on that one as well?
Please go ahead, Sean.
Yeah, for the CDC PT program, we are using the open source online database management that is available for other countries to adapt it and modify it for their use as well. So I don't know whether the country have the IT to help, but CDC also provide that service as well. So depending on the end user intention, what do they need to do? Do they just want to manage their own, or they want to share, like what Daniel has said, to be more connected of others within Africa for the country use itself can. Yeah,
important questions indeed. I hope I can try to bring in one who can represent the users. I can see Patience Tabula is online. Patience, are you there? If you are there, maybe you can help us on one of the questions that has been raised here. One, how do you select an EQA provider? And then you can, if possible, respond to Sean. Do countries need to do their own, or would they be willing to pick up from what CDC has developed?
Thank you very much, Anafi. I wasn't ready for taking questions, but nevertheless, I will then try to do that. I will ask you then to clarify Sean's question. The first one was my understanding, how do countries then choose, how do you choose an EQA provider? The ISO 15189 requires that the laboratories participate in proficiency testing scheme that mimic then the patient then results, but then it also then says that in compliance with 17043. So it would be ideal to look at EQA providers that are accredited on 17043, but that's not always possible and that's not always economic. As long as the supplies or is in line with the requirements for 17043, it becomes acceptable because the standard is not restrictive on accreditation of PTS providers. However, reality is that in this continent, we look at who's the cheapest provider. One, we go who's free, because then that will save us money. And the second is get who is then the cheapest. However, there are certain regional economic centers like SADC who have then had agreements with the ministers of health, had regional center of excellence for quality and things like that covered, and have advocated for the countries to participate in the EQA providers that are available. So there are those different reasons that you could consider and then choose what works easier for you. Where it's possible for you to develop an in-house, it is possible. And then I think I would advise that, but it's not always possible because maintaining and running a PTS, like Daniel was saying, is expensive as well. So you may be in a situation like us in our country where even though we have 14 histology laboratories, it doesn't become economic for us to provide that kind of a scheme. So you'd want to do, look at your costing, look at what Daniel was covering, and also then come back and look at what could be feasible and then take it from there. I'll be happy if, I know time is not on our side, if Sean's question can be clarified so that I can then easily respond if I can.
All right. Thanks, Patience. We appreciate for sharing the insights as well. Important points indeed. Maybe whilst we can come back to Sean, there is Kyle De Gruri. Hopefully I've pronounced this correctly. Kyle tried to respond to the first question earlier, which was asking how feasible is the 10% retesting. Kyle, are you there? All right.
Yes, I'm here. I'm here. Sorry.
Please go ahead briefly in a few seconds. Just respond to that.
Sure. I just wanted to let everybody know that it's also called blinded rechecking, especially in the TB smear microscopy world, which is beginning to shrink due to all the expert TB testing that's being rolled out. But for smear microscopy, essentially what happens is that a random percentage of smears selected randomly, whether they're positive or negative, are sent from a microscopy site to a reference lab. And the reference lab will reread the smears and then score the site appropriately and then follow up if there are discrepancies. There is a third lab that is a tiebreaker lab should there be a discrepancy, and that's essentially how it works. It is very time consuming, but has been employed in many areas and can be very effective.
Thank you very much, Sean, Kyle, for that as well. They kept on, I think people kept on bringing in the issues of sustainability, and Patience touched on that this can be really expensive as countries want to do that. And there was a mention of return on investment. How do we then convince our leaders, our governments to understand this? Sean, you mentioned that on return on investment. How could we possibly sort of bring this to people who could eventually fund the sustainable long-term projects going forward? Daniel?
Well, so typically there's a linguistic divide. So the ministry people don't speak laboratory, and laboratory people don't speak ministry. And so a ministry, if you could say to, and I always use the device of, you've got a minute to make the case for an investment by the ministry of why they should use external quality assessment versus the many, many competing alternatives for a budget. And what you would want to be able to say is, we conduct, we're doing testing which is shortening lives, this many lives, according to this curated data set in our country. We're going to focus on these programs, and collectively they represent this clinical impact. We're planning to get to the Pareto distribution, where 20% of the cost will cover 80% of the test volume, and we'll provide you with a report card, an annual report card, which shows how the impact of EQA. And we will create a statistic that says, based on EQA performance, that EQA has correlated to this improvement, and will have this clinical impact, and it'll save you this much money. If you can get to that point, there are very few competing funding opportunities that can have a systemic impact as a reliable test result. So that's the conversation that needs to be had, and that's the whole point of trying to distill everything down to a dashboard so that you can create this report card that can create a projected return on investment and then an actual return on investment using curated data. If you could have that conversation with the Minister of Health, the chances of you receiving funding and continuing to receive funding would be significantly improved than a conversation of invest in quality and here's this obscure process that's done in the laboratories and everybody says that it's good. That's not a very good message that's going to get funding from the Minister of Health.
Great. Thank you again, Daniel. Sean, there's Anna Malia. She says, since ILB on its EQAI program uses DTS for HIV rapid test, now for HIV viral load, would it be possible to test patients' samples, that is plasma, with this type of specimen treatment, as it would be more stable to transport and less expensive?
Thanks for the question. So are you referring to converting plasma to dry plasma for testing?
Yeah, it looks
That
like
sound
that.
like it. Yeah, so you would collect the sample and dry it out. So that will involve manipulating the sample and drying it out. So that will require the lab or the collection site to convert that plasma to dry it. So depending on whether the collection site have the ability or capacity to convert it. So all of our sample are done with the quality assurance. So everything is done under biosafety cabinet that is certified. So I don't know whether that would be feasible. It would be ideal if you can convert it, but I don't know whether that would be feasible for the country to change the plasma. I think even some countries have trouble getting the centrifuge to convert the whole blood to the plasma, let alone dry it to send it to the testing site. So that might be some barrier to converting it.
Yeah, really. So BSC makes it really quite expensive indeed. And but we need to make the point of sustainability in the end. So I think it's a conversation that we need to continue also having.
Yeah,
I know
there's
we are
if the country is having difficulty using the plasma for viral load, they can use the DBS, dry blood specimen, as an alternative. So it still can be detect a viral load level that is covered for the WHO viral load failure of 1,000 copy per mil. So DBS still can be used as a sample type.
all right. Thank you very much. We know we are almost just on time. Daniel, in 30 seconds, any closing remarks?
Yes. So wasn't actually prepared for that, but here's my summary. I think we have all of the ingredients to create a realistic, clinically effective approach within Africa, which would involve countries that are ready to either start or improve their national programs, and countries that need more time to rely on regional providers. I still maintain there's a need for a continental-wide provider where there is not a good regional EQA provider or a national provider. And when you deconstruct the elements associated with EQA to meet the standard, which is ISO 17043, you need to have an informatics system and you need to have a sample strategy. The sample strategy ought to be, let's make everything we can feasibly within our existing infrastructure, and let's procure from the outside using a group purchase model, everything else. And so I think that the pieces are there, and it now requires just a little bit of organization. And EQA, particularly in the COVID-19 world, represents a rare opportunity where economies are tied to an issue of the quality of testing. And so I think that this is an opportunity that is rare to focus both attention and funding.
Thank you very much, Daniel. Sean, just 30 seconds to give your remarks.
Thank you, Anafi. Yeah, I wasn't prepared for this one either. So I think depending on what the country testing volume as well as the number of labs, so the EQA may or may not be feasible for every country, but many countries are now decentralizing their viral testing due to the either the limited transportations or they just want to get in many sites in a remote region to test. So some country, even though they have used the conventional centralized lab, and also now trying to use the point of care. So this DTS viral PT can be used to GeneXpert machine. So we have some lab that are using for GeneXpert for viral testing can participate in this PT. So country will have to decide whether they have the capacity, not just the lab capacity, like Daniel had talked about, whether they have the funding capacity. So EQA should not be just for one time, have to be the lab intention to monitor their lab performance over time to see how they can help the lab to improve the lab quality, as well as how they can do the to help improve it using the corrective action as needed. So it's the process is not just only from the lab issue. So I'm only addressing here what is it require for the lab to produce the panel and what it needed to do, but it's in for pre-planning, funding, and the whole system, the program involvement as well for the sustainability.
Thank you very much, Sean. I'd like to thank our presenters, Daniel and Sean, for the wonderful presentations. There are quite a lot of important questions that are in the chat and we have not ignored them. So Daniel and Sean, I'd like to ask in the presence of all our participants to kindly share all those questions with you. And if you can kindly respond to them as soon as possible so we can be able to share with the participants. So I want to announce that for our country teams, we're still waiting for nominations for the sub-community of practice for M&E so that we can actually start and move forward. Daniel mentioned informatics. We are also going forward with the viral load awareness hashtag campaign. So please look forward to communications from our colleagues from ITPC. On your screen is the code for the August session. You can go to the ASLM Academy, log in, you can be able to print out your certificate from there. If you have missed any of these, you can still be able to replay this session. We will also send you the recording and the slides and hopefully the questions and answers as soon as possible. We shall be announcing our next special COVID-19 session in the next couple of days. So stay tuned and look out for this. Till we meet again, good morning, good afternoon, and good evening, depending on wherever you are. Bye-bye.
Thank you very much.
Thank you.